If you're studying for the NCLEX, lithium is one of those drugs you cannot memorize halfway. You need to know what makes the level rise, what to monitor, and the exact signs that tell you toxicity is starting. If lithium shows up on your nursing exam or the NCLEX, there is one concept you need to understand first. Lithium has a narrow therapeutic range. That means the difference between a therapeutic level and a toxic level can be small. For this review, remember the therapeutic serum lithium level of 0.6 to 1.2 milliequivalents per liter. But knowing the number is not enough. You also need to know when the level should be drawn. Lithium levels are typically checked about 12 hours after the last dose, so the result represents a trough level. Levels should be monitored closely after therapy begins or when the dose changes, and then periodically once the patient is stable. And do not focus only on the lab value. A new behavior change, confusion, worsening tremor, or change in coordination can be an early clue that the lithium level has changed. Now that we know how lithium levels are monitored, the bigger question is this: what can make that lithium level rise in the first place? What to monitor while on lithium? One of the most important things to monitor in a patient taking lithium is sodium and fluid balance. Here is the NCLEX connection. Lithium and sodium are handled closely by the kidneys. When sodium levels fall, the kidneys may retain more lithium, which can cause the serum lithium level to rise. That is why patients should maintain a consistent sodium intake rather than suddenly restricting salt. Hydration is just as important. Watch for fluid loss from excessive sweating, diarrhea, vomiting, fever, or poor fluid intake. Dehydration can reduce lithium clearance and increase the risk for toxicity. Kidney function also matters because lithium is eliminated primarily through the kidneys. Monitor renal function and pay attention to urine output. And remember, illness can change the situation quickly. If a patient develops significant vomiting, diarrhea, dehydration, or a change in behavior or neurologic status, the lithium level may need to be reassessed. But fluid and sodium changes are not the only things that affect lithium. Several medications can also change lithium levels, and this is a common testing area. Drug interactions and teaching certain medications can increase the lithium level and raise the risk for toxicity. Diuretics are a major concern, particularly medications that cause sodium loss. NSAIDs can also decrease lithium clearance and allow the level to rise. The key nursing point is that a patient taking lithium should not casually start a new prescription medication or over-the-counter medication without checking for interactions. Other medications can increase lithium excretion and reduce its therapeutic effect, including acetazolamide, theophylline, phenothiazines, and sodium bicarbonate. For patient teaching, keep the message simple. Maintain a consistent salt intake, maintain adequate hydration, and check before starting new medications. And teach the patient to report worsening tremor, confusion, difficulty walking, or other new neurologic changes. A fine hand tremor may occur as an expected lithium effect, but a tremor that becomes coarse or progressively worse should make you think about toxicity. So what does lithium toxicity actually look like? The symptoms often become more concerning as the serum level rises. Mild to moderate lithium toxicity. Lithium toxicity symptoms often begin to appear around a serum level of 1.5 milliequivalents per liter. Although the clinical symptoms are just as important as the number. With mild toxicity, you may see apathy, lethargy, decreased concentration, mild ataxia, coarse hand tremors, and muscle weakness. Notice that several of these findings are neurologic. That pattern is important. As toxicity progresses, gastrointestinal and neurologic findings become more pronounced. Moderate toxicity may cause nausea, vomiting, or severe diarrhea. The patient may develop slurred speech, blurred vision, tinnitus, muscle twitching, an irregular tremor, and worsening ataxia or incoordination. So, on an NCLEX question, do not dismiss worsening diarrhea, a coarse tremor, or an unsteady gait as minor side effects in a patient taking lithium. When these findings occur together, think about a rising lithium level. And once the neurologic findings become severe or kidney function begins to decline, lithium toxicity becomes an emergency. Severe toxicity and nursing action. Severe lithium toxicity is associated with levels greater than about 2.0 milliequivalents per liter. But again, treat the patient and the symptoms, not just the number. Severe findings can include nystagmus, muscle fasciculations, hyperreflexia, hallucinations, oliguria or anuria, and an impaired level of consciousness. At this point, the nursing priority is to stop further exposure and recognize this as a medical emergency. Hold the lithium and notify the provider immediately. Obtain the ordered lithium level and closely monitor neurologic status. Also monitor the cardiac rhythm, hydration status, kidney function, and urine output, because worsening renal function can further decrease lithium elimination. For NCLEX, think of the pattern this way: worsening neurologic findings, significant gastrointestinal symptoms, dehydration, and a rising lithium level should immediately make you suspect lithium toxicity. So remember the lithium safety sequence. Check the level correctly, keep sodium and fluid intake consistent, protect kidney function, watch for interacting medications, and recognize worsening neurologic and gastrointestinal symptoms early. If you can recognize that pattern, lithium questions become much easier to answer. Before you move on, ask yourself this. If your NCLEX question gives you a patient on lithium with diarrhea, dehydration, and a worsening tremor, would you recognize the danger? Save this review and follow for more NCLEX concepts you need to know.